Hi, everyone. My name is Dr. Michael Wald, and thank you for joining me again for another very important podcast. This one is 20 Ways Aggressive Prostate Cancer Can Be Missed. And this was prompted because of the recent diagnosis of former President Joe Biden's aggressive prostate cancer. And why would doctors who manage the president, how could they possibly miss this diagnosis? Well, I'll tell you in advance, I don't think it's any more mysterious than how regular physicians commonly miss things. They're just not thorough enough. So here we go. Let's begin by just mentioning that this information is not meant as a substitute for sound medical or health advice. It's meant for educational purposes only. You should also know that I'm a doctor of chiropractic and board certified nutritionist and dietitian and sports nutritionist. I also provide acupuncture to my clients and life coaching. I did also attend medical school. I earned my MD diploma, but I do not have an active license to practice medicine. So here are some very important things that we need to know about prostate cancer, some statistics. First of all, an alarming number of men are being diagnosed with prostate cancer, and the numbers are rising. 780,000 new cases expected just in 2025. 15.4% of all new cases in men is represented by this number. The average diagnosis is around age 67, with about 6 to 10 cases of these diagnoses in men aged 65 or older. It is the second leading cause of death among American men. It's estimated that there will be 35,770 deaths projected just again in 2025 alone. And the incidence of prostate cancer has been increasing around 3% per year since 2014, and many of these cases are in much younger men than the statistics that I just mentioned. So this is just a quick snapshot of some of the ways in which doctors can miss the diagnosis. I'm going to reiterate and actually just restate some of these later on in the next few slides, but I wanted to focus on these. So how do doctors miss such an important diagnosis? Well, some of them simply over-rely on the PSA or the prostate-specific antigen testing, which may not increase even with aggressive prostate cancer. There's also inadequate digital rectal examinations, what is known as a DRE, missing smaller or deep tumors. Because when a doctor does the digital rectal exam, he's only feeling one part of the prostate, and it's not the most common site that prostate cancer actually shows up. The biopsy, a sampling error may be wrong, where cancerous areas are simply not tested. So if you have a big tissue, like prostate tissue, and you're sticking a fine needle in there, this pencil represents the fine needle, it might simply miss areas where there's a tumor, for example, or cancer cells. Doctors also frequently overlook patient risk factors, such as a family history of prostate cancer. They just note it in their notes. Also, there's overlooking patient risk factors such as family history or ethnicity. So, for example, African American men tend to have higher risks of prostate cancer. So what about laboratory test errors and diagnosis? So normal or low PSA, that's again the prostate-specific antigen levels, despite aggressive disease. So we can't rely only on the PSA test. There's also failure to monitor what's known as the PSA velocity, or its rate of PSA increase. So if a doctor does a PSA test and it's at one level, maybe not so bad, and the next one's a little bit higher, the next one's a little bit higher, they're not following up. They'll say, oh, it's slightly high, doesn't mean much, or only a little out of the range, and then they send you off. And then if you come back in a year, 2 or 3 years later, the levels can be very, very high. So failure to monitor that velocity. You can only monitor velocity in a healthcare situation where you're in the doctor's office at regular visits to follow factors like this for no other reason, minimally, other than it's on the rise. Not calculating PSA, prostate-specific antigen density. That means the PSA number on the blood test relative to the prostate size. Overlooking high PSA in young men. So this is a problem. I just met with a person young man, whose PSA was elevated, and they treat and assume that they have infections, and then they send them off on their way. They'll sometimes give them an antibiotic. Sometimes the antibiotics are what manages an infection, obviously, but someone even with prostate cancer might seemingly respond to an antibiotic, and the doctor doesn't think twice about, oh, well, it was obviously a prostatitis from some bacteria. It may not be. And relying solely on the digital rectal exam. That obviously is an error. They teach you that, early on in medical school, early on in chiropractic school. I remember my very first patient in chiropractic school, we were practicing digital exams, and I said to the supervisor that I felt what I thought might have been prostate cancer, and he laughed at me. Everyone else laughed too, until he actually repeated the exam, and it turned out it was prostate cancer. Because sometimes you can get it, but many times you cannot through digital rectal examination. And as I've mentioned in my other prostate video, when you get your prostate checked, you want the PSA in the blood checked on the same day as the digital rectal exam, but make sure that the doctor does not perform the digital rectal exam first before the blood test. If the doctor manipulates that PSA through digital rectal exam, the PSA levels will be artificially high. That actually happened to me. I went into my urologist, as I mentioned in my other podcast, for the specific reason to see if he would do it in the wrong way, so I can tell you about it, and they did. And then they called me up and they said, "Oh my goodness, your levels are high. You must get these various scans." And I said, "No, the doctor did it wrong, so I'm going to come in again. We're going to do it again." And I'm like, "No." I'm like, "I'm coming in. That's how it's going to get done." They did the PSA first. No digital exam. PSA was very, very, very low. So sometimes they overdiagnose you and sometimes you underdiagnose. But the fact that this doctor and other doctors will do the digital exam first and then the testing, that's like the ABCs of doctoring in this area, and they get it wrong. In terms of other diagnoses, so we have biopsies, which can miss the tumor due to poor targeting of the biopsy needle, and limited core specimens. The core might go in this deep, but maybe you needed to go a little further. Also, the use of MRI is very important, and also it doesn't carry any radiation exposure to help guide the biopsy. Other doctors are like, no, I've been doing this for 30 years. I don't need MRI to guide. Wrong. Failure to repeat the biopsy after negative results with risk signs. So if you have various signs, and the signs, by the way, might be very similar to or exactly the same as benign prostatic hypertrophy. So for example, those would be frequent urination, urgency to urinate, weak or interrupted urine stream, difficulty starting urination, or what's known as hesitancy, incomplete bladder emptying, and dribbling at the end of urination. These are considered benign, but they might also be the same exact symptoms as prostate cancer. And then delaying biopsy despite rising or persistent PSA, not looking at those trajectories and failing to do biopsy. Ignoring lower urinary tract symptoms. So these are the basic reasons. And again, when I think of Biden, they couldn't even get his mental faculties right when he visited with specialists, which I'm assuming were neurologists, and they said he was fine. So they probably missed other things, but I do not know. So other diagnostic and laboratory errors, failure to consider the family history, like I mentioned, but not just the prostate cancer. If you have a family history of breast cancer, that also may be a sign of an increased risk of prostate cancer in a man. Overlooking race-based risk. As I mentioned earlier, African American men are at higher risk of prostate cancer. And then the lack of use of certain genomic or genetic markers like BRCA2, PCA3, and another one known as HOXB13. Ignoring a history of prostatitis or inflammation, and again, misdiagnosing that as benign prostatic hypertrophy, which is a benign enlargement. And assuming that men over 75 don't need to be screened because, well, they're not going to live much longer anyway. Believe it or not, that is a way of thinking by some doctors. There's also, of course, failure to educate patients on PSA test limitations, meaning that if you realize that the PSA test can also miss prostate cancer, you wouldn't simply rely on that. There are other tests to do, other cancer marker tests and other inflammatory tests. We'll review some of those in just a moment. And then inadequate follow-up after abnormal results. Sometimes people are called and told, oh, your labs are fine, or yes, your PSA was just slightly enlarged, don't worry about it. In that case, if the PSA is showing a mild increase, they should repeat that test in a few weeks. They just should do it. Some look at the test and say, well, it's not so bad. Wrong. Attributing symptoms to benign prostatic hypertrophy, which are actually prostate cancer signs. And I mentioned that 3 times because it's important, and I've seen it over the years. And also not referring to urology early enough. So sometimes you might go to your family practitioner, your internist, and there's problems with the PSA, maybe not too elevated, and they play around with your appointments rather than sending you to the expert. And then delays from insurance system barriers. The insurance may be limited. They might not cover the biopsy. There's time it takes to find out. And then you're left sort of standing in the wind. So I'd also want to mention, besides the PSA test and digital examination, there are other types of blood tests that I would do as a blood detective that span many different medical specialties, various inflammatory tests, immune tests, for example, maybe some cancer markers, and other tests specific to your needs. Those usually provide more pieces of the puzzle. So pictures might be seen to say, this doesn't look quite right. You'll simply, by testing more, you can see more. So that'll about do it for this presentation on 20 ways to miss prostate cancer. And I hope that you go over this 1 or 2 more times, commit a good amount of it to memory so you can help take care of yourself. Thanks very much, and I'll see you at the next podcast.